Okay, perfect. Well, it is the top of the hour, so we'll go ahead and get started. Hello, everybody. I'm Stacy Rothwell with the Oregon Office of Rural Health, and I would like to welcome you today to session number 2 of our CAH Quality 101 series. I do have a couple of housekeeping items and some information for you. We do have some great news for those of you that are seeking continuing education credits. We did find out from the OHSU Continuing Education Department that the last session on April 7th and today's session do qualify for continuing education. I did send an email to participants from the April 7th session that went out yesterday afternoon. So if you want to claim credit, be sure to complete the survey that was in that email. And then today, following today's presentation, I'll send out another survey via email to all participants, and be sure to complete that as well. We do ask that even if you're not seeking credits, please fill out the survey just to give us feedback on how the sessions were, and it'll help us do better in the future as well. There are some interactive portions throughout today's session, so please feel free to use the chat box down in the bottom right-hand corner of your screen. And also, we are recording today's session, so the recording and copy of slides will go out to everybody, and we'll also have those posted up on the Oregon Office of Rural Health website within the next couple of days. So with that, please join me in welcoming our presenter and facilitator today, Susan Runyan with Runyan Healthcare Quality Consulting. And with that, Susan, I will hand it over to you.
Great. Thank you so much, everybody. Glad that you came back to join again today, just 3 weeks later. Sometimes, you know, all of our meetings can be overwhelming. So I always thank people for spending the time to come back and dig a little deeper into quality. Today, the very first thing I want to do is really take a moment and pause. I did put something in the chat. Remember last time I told you that I really wanted these sessions to be interactive, and a first step for interaction that won't put you on the spot is to actually put something in the chat, okay? So I've asked a question, and I asked you to think about it last time when you left. So I want to know even one piece of data, where you display it, and what you or what you do with it. So, you know, if you send it in board packets, if you display it outside your office, if you give it to the director of nursing, whatever you're doing with it, just one component is what I'd like to hear from you in the chat. It's a safe space to just put a message in there and share with your peers. It's going to give us our first step as we're moving towards our open office hours next month, and those are pretty interactive. And so this will take a first step for you guys. Please post it to all attendees, and then just, you know, that will give us an opportunity to just start some sharing, all right? The best part about networking or being together is really finding even one morsel of something that you didn't know before, or something that you weren't, you know, familiar with, or a different way to think about something. So please do take the time to share. The other thing is, if there's any questions from last time's session, please put those in the chat or the question and answers. And as we move forward, Stacy can interrupt me. I won't be reading the chat, otherwise you'll just see me down here reading. And so it's distracting unless somebody brings something to my attention. So please don't hesitate. I would like it to be as interactive as possible in the safe space. I do understand it takes a little bit of time to feel comfortable sharing, but I hope that by the end of our time together in October, that we're really familiar with each other and have an easier time of sharing too. So today, we're going to spend time with data collection, displaying data, key points to measurement. Those types of things are what we're going to wrap our brains around today. So I talked a little bit about last time measuring success, but truly data helps us measure our success. It also helps us address things or identify things that might need attention or have the opportunity for a quality initiative to be done. Establishing a goal, the PDSA, having our aim statements, so goals or aim statements, having those things together, honestly, will hold accountability. Many times I would hear people say to me, "Oh yeah, like I told you last time, we do that really well." And where's the feet to the fire of we're going to start measuring that? How many times have all of us said we're going to start working on that? I'm going to start modifying my diet. I'm going to start exercising. I'm going to start a new initiative. I'm going to start working with other departments more collaboratively. But the accountability comes with setting a goal and really putting feet to the fire of a timeline as well. It really helps improve patient experience, safety, quality, efficiency, efficacy across the entire hospital. They can be short-term, long-term goals. In fact, I like to have a few of each. Definitely reevaluating on a quarterly basis. Are we moving in the right direction? But all the data helps us over time realize if we're making the right moves. Do we need to move down this highway of this crazy-looking highway in front of you, or are we really going down the path that is comfortable and still making change? Okay. Culture change takes time. So if you are in an organization, honestly, that that addresses or doesn't address quality as much as you would like to, doesn't embrace quality as much as you would like, I want you to take a breath and realize that changing of a culture takes time. You cannot do it on your own, but it still takes effort. So I've been to organizations, stop for site visits, and they say, leadership isn't on board, or we can't do this. And I say, well, then we need to find a different way to engage. We need to find a different way. Maybe the CEO isn't the right spot. Maybe we need to work in a small group with somebody else who has passion about the topic and prove the actual outcomes affect patients and affect our hospital in a positive way. I went to a hospital one time, and the CEO just said to me point blank, I don't believe in quality. It's a lot of mumbo jumbo, a lot of touchy-feely hand-holding. And I said, okay. I mean, I'm not coming to change your mind. If that's truly how you feel about it, that's okay. The problem with how you feel about it is it comes across to those in your organization, comes across to those in the community, that if quality isn't important, then what is? And so I had about a 30-minute conversation with him about how that statement sounds to the leadership team and to the organization as a whole, and just even to a frontline staff member to hear that your CEO says quality isn't important. Not only is that a pretty uphill battle, but he needs to think, is that truly the statement he has? Or is what he really is trying to say is that quality is something he may not understand. He may not understand the value of it and what really it means. And that is the part that we can help with. And we can help with it not only by lecturing him or spending time, presenting things to him or the leadership team, but by working at grassroots. Find something to work on and make successes sometimes despite competing priorities and competing philosophies. So some sample goals, just putting someone in charge. Sometimes very simple sample goals, sample things that you're trying to work on. Establish a patient family advisory council. That's a pretty big chunk. I'd like to break that goal down. That's a pretty big statement. Implementing bedside shift report is probably a great part of a good step of patient and family engagement, making sure it's patient-centered. Those types of defining things will make your goal much better. Improving patient experience scores by 5% across all units. Again, sometimes it's easier to do one unit at a time. Making sure that you have a timeline. So by the end of the year, and by the end of 2021, if I just put by the end of the year, then again, is it 2020, 2021, 2022? What year am I thinking? It's easy for me to understand, but not always for others. Reduce unplanned readmissions by 10%. Again, is that one unit? Is that all units? And then by a timeline. So making sure that your data has a strong understanding. So basically, data and measurement help us understand variation in processes. Monitor processes over time, we've talked about that. The effect of any change that we do, remember we talked about last time, one change at a time so that you know whether it really has made a difference or not. It really provides the common reference point and clarity of the goal. So if you're trying to display data, which is what we're going to talk about here in just a minute, remember you always want to be reminding yourself what was our goal, what were we shooting for, who's our audience as we really work towards displaying data and what measurement we're really looking for. It also gives an accurate base for prediction. Keep it simple. So I believe there were 2 of you when we asked what you were really interested in our Quality 101 sessions, and a couple of you talked about different types of ways to display data. And I'm going to show quite a few today, and I'm also going to show you really my cheat sheet of data display. But if I have to say one thing, I will remind you to please keep it simple. And by that, I'm just saying the data should not be so complicated and so complex, one, that it's kind of tiring to read. It shouldn't overwhelm a page. It should be simple and straightforward, enough that you understand what the person's even trying to tell the story of. Make sure you hold to the original question. Like I said, make sure that we are really on task with what it is we were trying to answer, if you will. We want to communicate the actual findings and make sure that any variation is understood and kind of displayed or talked about during the time. Ways that you can use data, certainly for research, accountability, clinical management, improvement opportunities. You know, maybe you're not sure if something is going right. And certainly the research part, making sure that you have proof of a concept, you know, making sure that your sample size is big enough. Most physicians, medical staff, they really want data. And they really want to understand exactly what you're trying to talk about. And so when you're going to go with them with a concept, having some data to prove why the concept is something you want to work on is certainly going to hold more water for you as you try to, I don't want to say convince them, but you certainly try to display the story that you're interested in talking about. Ask yourself, as you're trying to think about things, why are we collecting the data? What are we going to collect? Where's it coming from? How are we going to do it? Who's going to do it? And how? Are we going to do a retrospective kind of analysis of what we already have? Are we going to look at billing or lab or pharmacy kind of administrative things? Are we going to look at any, external requirements? Your MBQIP requirements are external, so your EDTC and your quality net type of things. Maybe you have some HQIC requirements going on now. I'm sure that you do. And then just other regulatory things. HCAHPS surveys are a great understanding of things that that you already have data sources for. HCAHPS, I like to focus on that a little bit. You've got a customer voice. I mean, because there's not many things in data that you would have a customer voice for. It identifies certainly opportunities for improvement, sets some priorities, and evaluates progress over time, and by all means, tells a great story. I get asked many times about medical records abstraction, so kind of retrospective looks that definitely have rich and detailed information, certainly has lots of information from the clinical side. Sometimes the documentation is just poor, and that's kind of the first step. So before you can even move forward, in Kansas we have, for example, lean projects that we do, and so we'll have like a 4 or 5 month project on lean, and people will come in and they'll say, we want to work on our billing process. And, we have too many accounts in various stages. We don't seem to have a consistent process. We're losing money. We're not coding correctly, a plethora of things. But when we get down to what they really have to work on before anything else is their registration process. They have to streamline the registration process so that all the documentation is done consistently. So again, maybe you have a lack of consistent clinician documentation, and that is something that needs to be looked at. Maybe you don't have a quality problem necessarily. Maybe you don't have the particular problem you thought you did. You just have physicians or mid-levels or nurses or whomever documenting it in 10 different places. And so if you're using your EHR or auditing from certain spots in the medical record, you might realize that we need to do some education before we can really do a measurement. Privacy issues, missing data, time and resource intensive. It certainly takes a ton of time to do a retrospective analysis on a medical record. Track your progress early. I used to have a CEO that told me, we don't want to make too much improvement before it's mandatory. So one time we were a PPS hospital, very small, like I said last time, and we knew that pay for performance was coming. And he said to me, look, Susan, we don't want to focus on these things too soon, because then our measure is going to be, we're going to be at, 80% of the time versus right now we're at, 60% of the time. So if we do too many improvements before the baseline, then we're really setting our mark even higher. Now, I understand what he's trying to say, but certainly tracking your progress early on gives you the best opportunity for measurement of success. It gives great positive feedback to your staff about just how far they've come. If we didn't start measuring something until we were 80% and we'd already made improvements enough to be from 60%, we're missing an opportunity to celebrate the 20% of huge movement that it did take to get there. Develop your plan. This is back to the accountability, making sure that the format of information is going to be shared, and also what type of forms do you use in your organization? Are they standardized so that when you have quality improvement activities in your departments, are they looking at things and documenting things similarly? Don't recreate the wheel. If one department is doing something, take and see if another department is interested in a similar topic, could they take a spin off of something else? Or, one of you guys, if you're working on a particular type of project, are there lessons learned from others, who have done something similar in your state so that you don't even have to kind of reinvent that wheel altogether? Once the goals are defined, definitely find, the key to success is going to be measurement and indicators, and making sure that the indicators that you're using are actually those that will show the movements that you're making. Sometimes we're too broad and we have to be specific in a measure in order to show or analyze the data specifically. So things to consider, what's already existing? What are you already working on? Again, limiting your number to 1 to 3 or so key indicators to focus on. If you sat down with somebody and honestly shared every piece of quality data that is analyzed, that is abstracted, that is exported to some location. In fact, that's usually a challenge that I give to most people when I'm helping analyze a quality program. Is I want everyone in the quality department and even in the quality committee to write down on some whiteboard every piece of data that they collect in their department, every piece. And when you really look at it, what are we doing with the data? So I know that you have regulatory reasons to gather some data, and I understand that. But if some of you are involved with MBQIP or data gathering just to get a check mark because you want to say you're doing it, boy, that's wasting your time. Find something that really adds value to your day, really adds value to the patients, and that is what's going to change culture. When we talk about culture, finding something that somebody's passionate about absolutely will let them see the value of what quality is. Now, usually I would pause here a little bit. I don't have much time to pause today because of my snafu, but are there things, Stacy, and I have not pulled back up I'm just fearful. I'm not going to touch it. I haven't pulled up my Q&A or the chat. Is there anything roundtable-wise that we want to talk about or readdress at this point right now before we move into displaying data? Stacy, do you see anything there?
Susan, there's nothing new aside from the answers to the questions from previous.
Okay.
Yes.
Okay, So keep sharing how you're displaying data, what you're doing with data. I would like you guys to keep sharing. So keep being in the practice of sharing what I've asked. So if you haven't taken the opportunity, please do so. So this second half is going to be on how we display data. And I talked about already, keep it simple. So some of my slides here, these always bring a smile to my eye. So a smile to my face and makes me happy. So these people have taken data or taken a very simple message and made it very clear. So they're trying to inform and educate, which is part of what you're doing with data display, part of what you're doing with quality initiatives. Is part of that is education. And so here is a nice little snapshot of when you should use urgent care versus the emergency department. Again, they've kept it very simple. They've made it very clear about when you should come see them in certain capacities. And then this, I have the plague. That was many years ago when I took these pictures. So it was certainly before COVID, which unfortunately some people would equate to the plague, so I'm not sure that they would use this particular one. And so that's the other thing to think about, sensitivity, making sure that, yes, you have a clear message, you're telling a story, you're keeping it simple, whilst you're not confusing people or upsetting anyone as well. So you would never want your data to cause anyone stress or make them, offend people immediately right away. So when you display data, I definitely want you to figure out which audience you're trying to talk to. As you're telling the story, are you trying to talk to the medical staff? Are you trying to talk to your infection prevention committee? Are you trying to talk to a group of volunteers? Are you trying to talk to frontline staff? And keep the original question in mind. I can't stress that enough, because it really, data should describe any variation. And so there are a couple of ways that you really can, depending upon your data and length of time, and we're going to look at some specific examples here in a second about what might hold the best clues for displaying the data as you move forward. Remember, data is all a matter of perspective. So it's very simple for the person creating the document to see it. So if you're the quality director and you're putting your slides together, you're putting your graphs together, your tables together, and you're on the island, you see the boat and you know exactly what the boat means to you. But if you're the person in the boat, your audience in the boat, they see land, they don't see the boat. So their perspective is completely different from yours. And so that's the other takeaway I would really encourage you to do, which doesn't seem like a great bit of wealth of knowledge. However, it has served me well as I've moved around in the years in this job. Find someone else in a different department other than where you're trying to display the data to look over what it is you've created. So if I'm going to, if I put this table together and I want to give it to the medical staff, right, during my quality committee with the medical staff, and I want to talk to them about these numbers, right, I'm going to take it maybe to someone in the business office and say, tell me what story I'm saying. What do you read from this? And if they tell me they don't understand it, then I better figure out why. All right, so I don't want to use a physician. I don't want to use a mid-level. I don't want to use somebody who's familiar with the data that I'm doing. I want it to be so simple that anyone picking it up would understand what it means. And so if a key takeaway today for you for data display, please take it to somebody else. Take it to physical therapy. Take it to someone in radiology and tell them what it is, let them tell you what it is you're trying to display, all right? So a table, very simple table. Sometimes that's all that you need if it's really just quickly talking about numbers. Now, if I had the chat up, you've already thought about, as you've looked at this, what the problems are with this table. It doesn't tell you a number of what, all right? So the number, is this admissions? is this the number of errors? I mean, what is the number, all right? The other thing is it over a certain amount of time? That's relative, and that helps paint the picture. The other thing, it definitely, I don't know if that's good or not. Is 6 good or is 2 good? You know, are we displaying this in a positive light or the negative at the top? And out of how many? Is this a 1 day, 1 week? The other thing is out of how many people? So 6 out of 10, 6 out of 6, 6 out of 6,000? I don't know. So when you're looking at data, this might mean a lot to you, but when you take a step back, it might not. It might not be telling the story that you want to tell. For graphs, it certainly has the ability to display data. I use graphs probably more than anything. When I finished my master's degree in, I want to say 2016 or 17, and of course was working at the time and had to do a lot of work around graphs, a lot of work around data display, and a lot of complicated graphs and spider charts and splatter charts. We're going to get to a few of those here in a minute. And what I've boiled down to in real life application is that a graph tells story. It tells the types of things that I want to tell in a very simple way. I have problems with this graph because I like to post a few things that would make you think, well, I don't understand. Exactly. So when you're looking at this, what else would you put on here? You know, this is the same data that we just had on a table. So you've moved it to a graph. Well, again, is this good? Is this bad? We don't have it in a Pareto chart. We don't have it going in order. This is just in no particular order. Do you want to alphabetize them? Do you want it to go from greatest to smallest? As you're considering those things, that's the type of information that you'd really want to focus on. Remembering again, what's the question? Who's the audience? And what essential information? So you don't need a ton of other background noise, but you might need more than one graph. All right, you might have 3 or 4 things to display that could possibly fit on one graph, but it might also cloud it up so much that you're not able to convey the point. Some people ask me, you know, basically kind of the difference between a bar graph. Here's an example of a Pareto chart. I talked about, you know, from in order of number. So it takes something, it's just a type of bar graph, and it just puts it in order of frequency, or you can put it in basically it's a numerical or a order of frequency. So it might be a number or percentage, but it does do a rating, if you will, and puts things in a certain fashion so that it does add some order to your chart. I'm a personal, this is of the other types of charts or graphs that I use a run chart. So when we've talked about doing only one thing at a time in quality improvement, doing only one change, seeing how it goes, and then measure, and then implement another change if we're not happy, measure, see where we are, implement another change. The run chart is a perfect example of that. So this particular talks about median length of stay for, and I like this one because it does several things. It gives us the time in weeks, so we know that we're measuring weeks down here. It gives us the median length of stay for patients admitted. It tells us who we're looking at, so admitted from the ED, and these are the doctors and the med assistants that we're looking at, all right? Length of stay in minutes, so that's the other thing. It qualifies what it is we're looking at. And then every point on there, we have the opportunity to say what happened, what was going on that made the difference. So the very first thing was we added quick look x-rays, let's say. But actually our length of stay went up, all right? Well, do we keep those or not? Let's talk about that. And then the next implementation was a workup done on the floor. Okay, then we measure again. That had a great improvement. we measure a couple more weeks because we think if this is the trend, that just adding those two things are going to keep us going down in our length of stay, down to our goal, then we don't need to throw more things at the wall, all right? But we take a couple more measures. You take the next measure that's on there for 413, and you see that it went up. But again, was that an anomaly or was that truly a trend? So you keep kind of measuring, weighing things, and we do a bet ahead. We call ahead. You know, these types of points in time talk about so much more painting of the picture versus if you just had these markings on a chart without the specific spots, okay? So for me, a table, a graph, a very simple items, or for something that's going to take a bit more time, I would do a run chart. Those are kind of my top ones. A splatter chart, I had a physician one time ask me, why don't you have this in a splatter chart? And I had to look up what a splatter chart was. That was early on, but I don't have much. I've personally, it's not a chart, graph, or display that I have found much value in. Not to say that there isn't for my particular type of work or how I see data. That's the other thing that you, in your own setting, will decide for yourself is what's easy for you to convey the picture for. This really is a demonstration of a relationship of two kind of parameters. And so if you are doing wait time and satisfaction and you can scatter them out, and this makes sense to you, it certainly is what that physician wanted to see. So I went back and created a couple of scatter charts for them. It really is just the relationship of very specific types of things and over time. So this, again, doesn't tell enough of a story for me. I mean, how long were we measuring this? Was it, you know, was it a week? Was it a day? Was it just one snapshot of time? Was it a month? I mean, was it just these 7 people? What made the population in this particular plot, this particular demonstration of data? And so again, the next one, a control chart, definitely is for special causes. It will definitely help you display things. If you have an outlier, we had an example where I did use this. We had a high number of falls, and we had one particular patient who, unfortunately, really no matter what we did, and we, you know, finally had family or staff that had to stay with the patient. But we had some special causes. I mean, he was constantly falling, and even when the family was in there. And so it is a great way to display. It's statistically sound. It is more because of a mean being in there and because of how it's displayed, it may not resonate with enough a broad variety of people. And so that's another reason that it might seem too controlled. That's a great one. I was going to say that. It might seem too rigid and not telling enough information. You know, it can be misleading. It doesn't, because it doesn't tell enough, so it might not be the right fit. When I talked just a minute ago about being in class, I want to bring to your attention, and I know that you all might be able to see me. So my favorite, if you can pick this up, if you don't have this already, called the Memory Jogger 2. They have memory joggers for a ton of things now, but in all honesty, and I'm going to try to make it to where you can see, I should have done maybe a couple of screenshots, and maybe I will for our next time. I'll do a couple of screenshots and show you what it looks like. But this is a little pocket guide. You can see it doesn't even take up my whole hand. but it's called the Memory Jogger 2. It has continuous improvement and effective planning. They're like $7 or $8. No, this is $17. Sorry, $17 for this. It has every chart, graph, every possibility of anything. It helps tell you why you should use a certain type of thing. Like I said, I bought it back when I was in college because I had to do so many graphs, and it really helps me understand for my purposes, what would be best that fit with my brain, as well as what would fit with people that I was going to be working with, the audience that I had. The other thing, if you're working with teams or you're facilitating meetings, certainly as the quality director, those are things that you're having to do, which is work through things. There is the team memory jogger, and you can actually buy this for an entire team working together, but it's how to work through meetings, achieving goals. And that one, at least when I got it, that one I've had forever, and that says it was $7.99. So anyways, a couple of resources that I really have a go-to. I put here on my picture, I have the original Memory Jogger. The Memory Jogger 2 is just a newer version, but I looked just yesterday, they had lean memory joggers, tons of those anyways. So those are some resources that I offer up to you guys if you're interested in exploring other ways to display data that you might not, be as familiar with. It walks you through how to create them. The fishbone diagram, all of those types of things are in there as well. I have put a couple of things in here because when I've worked with, this is a hospital in Idaho that I've worked with, and they were really struggling with their quality program. And I said, well, I can tell you I don't see any quality data around here. And so they worked on an entire campaign because what they really needed to be able to display and help their patients and their staff understand was what quality even was, all right? And so they built an entire campaign, which these are the latter side of that campaign, but around the pillars and what quality even meant. But if you're going to have an audience and you have someone who is good, this is actually a marketing company who put these together for her. But if you have someone in marketing or someone who likes to do visual display, this is another beautiful way to display data that's really eye-catching. If you walked down the hall and you saw this on my bulletin board, okay, versus something like this is eye-catching. Now, I don't say that you can, in fact, where I came from, I never used anything like this. We didn't have a budget to do anything like this. And so, but again, maybe a visual, maybe, what we want to talk about, what we're doing well, and they talk about what we can improve. So they talk about medications, adverse drug events. They talk about, where they are and where the national average is. So they're doing well there. They talk about what they can improve upon with medications. And then they talk about an antibiotic stewardship. So it really crosses then to an infection prevention. And then it really talks about patient empowerment or patient family engagement. So this type of graph or display not only helps your staff, it gives your visitors something to do, it helps your patients, but maybe just a piece of it, maybe just the portion of prevention of adverse drug events. Maybe that's something that you put in a newsletter. And if you don't, if you have a newsletter that goes out or an employee email or something, someplace that you could display, but finding visually intriguing ways to display data is valuable, not only to your staff, it draws their eye, but also to the patients and visitors for them to understand what it is you're working on. Another simple thing that I tell you about data is you really have to talk about what you're doing well, and you have to talk about what you're not doing so well, or what you could improve upon, what you are improving upon, because data's out there. People can find what you're not doing well. They also probably read it on Facebook. They talk about it at the donut shop where I came from. If I ever wanted to know something, I would just pop on down to the donut shop. When I first started working where I worked, after a while they got to know who you were. It was a small town, but I would just sit at the donut shop and listen. I learned a lot about what they thought we could improve upon. And so again, when you're displaying data, thinking about your audience and what's visually pleasing. You know, if I'm going to a meeting with a bunch of physicians or talking about a process, I'm not going to go to marketing and have them work up a new run chart for me. I'm going to create that myself. But if I'm really talking about a campaign or talking about ways I could display things that would invoke conversation, would demonstrate quality and different levels of care and what we're really focusing on and empowering patients, I'm going to work on different ways to display data. This was something that they did for COVID when it came in, and they changed and shifted gears and did a little bit so that they went around the pillars of quality so that, we talked about that in the last time, the 6 aims. So safe, timely, efficient, equitable, patient-centered, and effective. And so they framed their entire quality program around that type of structure. So when it's talking about this particular thing, she always wanted to create, what part of, providing external data reporting, that's equitable. So she put them all in the pillars to keep demonstrating and driving home what parts of the quality initiatives were being addressed with every part of the work. And so she did that a little bit on this as well. But again, working with an outside agency, or if you have someone in marketing or someone who just likes to put a nice slide together, you could do that. What are we doing well? Find an image of the pill bottle, put that data on in one slide, and you could really not have to be a whiz at marketing. I could never put something like this page together for myself, but I definitely could put together a different type of display of data. I'm going to keep moving on Roundtable. Stacy, if there's anything that comes into chat, again, please let me know. I want to basically summarize. You should be celebrating your successes. What is telling your story of success? Report somewhere, at least quarterly. Keep the data. If you've got a quality, bulletin board, I hope you do. I hope, that's the first thing I do when I go in and evaluate a quality program at an organization. I don't do it here in Kansas because people would know me here, most of them, but I like to do it, like I said, I do it out of state, and so I get to go in and I'm kind of the secret shopper. I go to their cafeteria and I sit and I eat lunch alone, and I listen to how the staff talks about patients or the hospital or whatever they're talking about. They might just be talking about their day. I listen to the patients and the families and what they're talking about, and then, I look around and I see, what if they're displaying things, where is it? How old is it? How long has it been there? Some people will put up data and then they don't look at it again. If you go to your website, that's the other thing I do. I go to the websites before I show up. You've got data out there. Well, is it from 2019? How important is quality? People are looking for clues to understand how valuable you find quality and patient safety to be. And if the clue is that they find that you have data from 2019 out on your website, and it's just probably an oversight. We built this page maybe on our website, and we've forgotten that the data is there. Well, it's not that quality is important. It's certainly not that you haven't measured something since 2019, but we've just forgotten about it. And so making sure that it's reported or updated at least quarterly. So if you're going to display it, which I think you should. I think even if it's in a staff lounge, that should be much more than quarterly. If they're working on a current initiative, you should have some sort of data that's telling them how they're doing practically every week at least, depending on what you're measuring, depending on what you're doing. So celebrate and highlight the successes. If I have 100 pounds to lose, I better celebrate every, 10 pounds or something. You know what I mean? If you wait until you lose it all, or if you wait until you reach the goal of 95%, that's not as encouraging as small goals. So celebrating and highlighting successes is very important to do. Internal and external communication channels, I talk about Facebook. I'm sure your hospitals have, most of you have a Facebook page. You should be posting certain things about quality. Even if it's a patient comment from an HCAHPS survey, beautiful. You don't have to identify that it's Susan Runyan from Derby. Stacy, can you all still hear me? Oh no. Eric, yes, can you still? Okay, all right. I just saw it pop up that, okay, thank you. Sorry. Okay, I'm going to see, that's why I don't read the chat. All right, so share your successes and perceived failures. Please don't always be rainbows and unicorns. That's why I say you should be telling things that you are working on. So internal and external communication channels, working in your newsletter, work on your Facebook page, work on your website. Utilize those sources of places and opportunities to talk about quality. They're not a big paragraph about what quality is, but a snapshot, one thing. Find one or two things you want to focus on for a while, and then keep the focus on it until you make some improvements. Again, if you're not doing so well, I'm betting your public probably knows. And so showing that you're making an effort to make it better is vital too. Show the story. Don't tell people about it again, not ad nauseum in a paragraph about all of the work that you're doing around falls, but demonstrate it in the data. Tell the whole story, not just the goods or the bads. Use the data that you have. Don't trust when people are like, oh, well, we know we do that very well. We know we always do that. Keep it simple. So I know that there's a propensity to think, I've got to come up with this beautiful graph and make sure that it's got all of these things in my lifetime. Tables and graphs are the simplest form that I can use to tell my story and not overcomplicate it with 50 different data points, right? Use available reports. If you already have things that are created, please utilize things that are already available to you. I love this quote from Quint Studer. If you've ever heard him before, he's passionate about quality and patient safety, but the more often we measure the important things, the more we'll know where we are making a difference and where we are not. And the more we know, the more we can actually affect behavior. So it's easy to say we're doing great. We don't have anything to work on. We don't have any quality improvement needs. But in all honesty, we have tons to work on. It's just we can't be so overwhelmed with all that we have to work on that we don't do a good job of displaying or focusing on certain things, making those improvements, and then moving on to the next item. I'm going to briefly, as I move to kind of one of the last couple of slides, just talk again about the difference between open office hours and kind of the experiences that we've had so far. So the open office hours, I really will only have about probably 15 minutes or so of content, and then the rest of the time will be spent networking and talking about certain things. I know from some of the questions and comments that you guys have brought to kind of in that pre and then in an evaluation, some things that we talked about last time, root cause analysis and event analysis. And so that's going to be something that I talk about a little bit. But the hope for the open office hours isn't just to hear me talk for another hour. It is to actually network with each other and to talk about things that I can help facilitate and bring more conversation about. The other thing was quality and kind of a QI department and roles and responsibilities, kind of the things that you all are doing in your particular departments. That's valuable as well. And then the last slide I have to show, because we are doing continuing ed, is that we have no financial disclosures, no faculty disclosures for anybody who planned or instructed or moderated today. So, wow, I've never had as bad of an IT issue that I had today. I so apologize for that, but I thank you all for holding on. I will always now write down my access number, so I will never have to do that again. Stacy or Eric, anything in the chat that we want to focus on?
I haven't seen anything new in either place.
Okay, all right. If you did not have opportunity to share where you're displaying data and what you're doing with it, please do. And if you didn't have a chance to read it over, read those over. Stacy, are you on or have any closing thoughts for today? I think we might have lost Stacy. So there we go. We got another issue. So sorry. So I'm going to close this out. I thank everyone. Please do the evaluation because one, that's how you get your continuing ed. And two, we definitely want to hear your feedback of these sessions and what you want to know in the next sessions to come. So when we're working on open office hours again, I'll focus on anything that you guys are interested in, and then we have to talk to each other. So that's the beautiful part. So I'm looking forward to it. Our next time is May 26th, if I remember correctly. Yep, May 26th at 10 o'clock your time. And I look forward to it. Eric, anything they need to do, or they just need to close it out, and we're going to turn off the recording?
Yep, everyone's good to leave at this point, so just click that red X button and leave the session.
Thank you, everybody, for hanging in there. I appreciate it.